yourself?
I am fabulous. I am fabulous for now. Let me preference that. Yeah. But it's been a long week. I just feel like it's been a long week. Okay. I hear some noise. I don't know what that noise is. Is it me? Is it
I
you?
don't.
I hear something rumbling. Okay. Maybe it's just me. Alrighty. Righty. Well, let's get this party started this morning. I got some stuff. I got some stuff.
Okay.
I got some stuff. All right. So if you have been around for a while, you know what this is all about. Welcome to the Saturday Morning Tea, where we discuss health information, news, education, and certification tips. I am Clarice Warner, the girl with the, I don't know why I keep looking up over here. I'm seeing my camera over here, but that camera is not even on. I done shifted the whole world, and now my mind is like, look at the camera, look at the camera. No, ma'am, look at this camera. Okay, I'm sorry. I just had a moment. I am Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co-host and deal into the other shenanigans of the morning, today's episode is sponsored by the Professional Reimbursement Network's free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Okay. It might be the wind. Wait, I have a ceiling fan going. Maybe that's it. Hold on. Which I normally have a ceiling fan going. That's not it. I don't know. Okay, I'm
I don't
sorry.
hear anything on this end.
I hear it's like something buzzing, moving. Okay, whatever. I'm not gonna worry about it. All righty. So if you are interested in the 5 steps to become a certified marketable medical coder, and you are,
Tanika said in the chat, it sounds like the wind is blowing.
yes, I hear something like wind.
I know what it is. It's my fan.
It's you. Look, I done turned my whole fan off and everything.
All right.
I'm like, what is that noise?
Are you still here?
No.
Okay, it's the fan.
See, I know I'm not going crazy. Okay, so if you are interested in, see, it's going to be one of them days already. I feel it in my spirit. If you are interested in the 5 steps to become a certified marketable medical coder, and you are on Clubhouse, then feel free to hit the link at the top of the page. If you are on YouTube, Facebook, and or LinkedIn, and I got to see a LinkedIn replay, so I was excited. Okay, and LinkedIn, then the information for the 5 steps to become a certified marketable medical free email course is in the description box. So joining me today is my illustrious co-host who had a fan going in the background making me think I'm going crazy. Mr. Jesse, the registered trademark, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I've been an LPN for 29 years. In 2014, I transitioned into HIM. And during the pandemic, I created my company, The Coding Nurse LLC, where I help nurses and other healthcare professionals with clinical experience transition into the world of HIM.
All right. And how's that going for you?
It is going pretty well. I had a student last who she took her CRC last week, and I think it was Thursday. She texted me and told me that she passed, and I have another
Yay.
student who is testing right now.
Okay. Well, let's see. Hey, Tanika. Hey, Janelle. That's sitting with us here in the clubhouse. And then we got, hey, Dr. K. I am well. Mr. Jesse, are you well? Well, look at here. Somebody sliding in on my thing. That's my husband. Good morning, love. Good morning. Let's see. The healthcare consultant. Hello and good morning. Good morning. Thanks all for joining us. Yes. Like I said, we're gonna have a morning today. So if you are on Clubhouse and you want to join in and add to the conversation, we're all family here. Please raise your hand. Don't be shy. Your opinion and your comments are welcomed here and they matter. Okay, did something fall and crash? I don't know what that was either. So
that was me. That might have been me pushing my earpiece.
I know. For for my Facebook and YouTube friends, you all know what to do. Oh, and LinkedIn. I'm sorry, and LinkedIn too. Now, unfortunately, for the LinkedIn folks, you won't see any information that I push, but we'll see all your comments. The one thing that I do ask for anybody that is using the chat for questions is that you put a Q in front of your question so we know it's actually a question. We do still engage with the opinions and the different comments and the laughter and the joy and all of the tea that is spilled here. But we want to make sure we get to your question. So if you can just identify it with the letter Q in front of it, that will help us tremendously. So let's see. Any more housekeeping rules, notes? Oh, okay. This is an aside of a housekeeping note. So remember, I'm always talking about where the money reside, right? And I thought the original place where I heard that from was from P Valley. Don't judge me. I love that show. That's a whole other conversation. But anyway, so Pastor Woodbine, who is probably one of my favorite characters because she is off the chain. She talks about where the blessings reside, but she got that from where the money reside, which is where I heard it from. Well, I'm all about folks owning and owning their stuff. So Darrell Smiley, who is a car salesman in Louisiana, actually coined that phrase, where the money reside. He has it trademarked. So I'm just, I'm all about folks owning their stuff. Sir, I don't own nothing, but we just use your stuff. And so I want to give you your flowers and your props. Mr. Darrell Smiley, car salesman in Louisiana. And actually there's a YouTube video. I started to show it. I'll show it next week. How about that?
He's now a reality TV star.
Oh, well, look at him. He done came all the way up because he popped up out of a Honda talking about where the money reside. And folks was like, if I go into a car dealership and the salesman don't pop out of the car, I'm not buying anything. But anyway, so I love where the money resides. I will continue to use it, but I wanted to make sure that you got your props. All right. And I may even use Pastor Woodbine's where the blessings resides because we get some blessings here as well. So with that being said, that's all my housekeeping stuff for today. All righty. So couple of things. If you have not heard, the AAPC are doing some different things over there in the world of certification.
Aren't they?
Yes. Let's see. Ricky said you need to turn your mic up. I actually can hear you, but Ricky said you might want to turn your mic up. All right.
Oh. Okay, I've turned up the volume on my headphones.
Okay. So yeah, they're doing some things. So, they made a whole bunch of changes in January, and we've talked about them over and over and what we need to do to be prepared for those changes. But what they're doing new now is that all certification exams that they offer will be available in an electronic format for most members. Now there's a asterisk around most members, and India. They still got to take papers. Sorry, but everybody else can take it on an electric format, and you can take it at a time and in a location that's convenient for you. So I think you can still have the option to electronically take it at your home and have everything set up with your proctor, or you can also go to a testing site where you can take, similar to what AHIMA does with their examinations. So everything else is the same, specifically with the CPC exam, 100 questions, 4-hour format. Now, one of the things that I wanted to make mention of as it relates to this was, where did it go? They talked about the experience. And, so the examinees will be able to view a select number of questions at a time. So you don't get to see like on paper, you get to kind of go shuffle through and go. And so it's not one question at a time. You get so many questions, and they didn't say exactly how many of those questions are, but you get so many questions at a time, supposedly to allow for better focus and concentration. You will be able to highlight information in the cases, which is placed next to the question. So you can view like information that you're highlighting or things that you think are relevant in order to answer the question accurately. And then you also can flag questions to return back to them later on and answer. And so you can navigate between sections and questions of the exam. Instead of turning pages, you can just like click something. And there is a digital timer that will be constantly displayed as you move through the exam. So those are some of the things that the AAPC is providing to you if you're interested in taking any of their examinations. And I saw somewhere else that they're actually phasing out the paper exam. I saw that somewhere. I'm not seeing this right here, but I saw somewhere that was kind of the goal, was to phase out. So I'm curious on what that does for local chapters, because that was part of the revenue for local chapters to be able to proctor the exams, especially if they do away with it. If they keep it as an option, then okay. But if they completely do away and go electronic, which I think a lot of people actually want it. They've been asking for this for years. I'm just curious, what does that look like for the local chapters? I may need to ask somebody.
That's interesting, because I've taken 3 AAPC exams. I took them at 3 different chapters, and some chapters really, really, really go all out when they proctor an exam. I mean, they pretty much have a daggone welcome wagon.
We did. We had all of that. We had everything but books. You had to bring your own books, but we had, the peppermint, because we believe the peppermint helps stimulate your brain and keep you alert. We had all of the things, and yeah, so this is gonna be interesting.
And what I also, the other detriment I see is it is a possibility. It's a networking opportunity as well.
And marketing, because if you didn't know about your local chapter, this was an opportunity for you to meet the people, interact with the board, and know where they're meeting, and just get connected into that. So yeah, I think that's yeah.
Because real quick, when I took my billing exam, after my billing exam, I left the room, because you know how the proctors relieve each other, because it's a long day.
Oh, very long day.
But when I was leaving, I went to the proctor who had been in the room for the majority of the time to ask, because I was taking my CPMA I think 2 or 3 weeks later. So I was asking her about the audit sheet that you can bring. So there was another woman next to her who was just, working. She had a laptop open. So she said, are you taking your CPMA? I said, yeah, I'm taking it. I think 2 or 3 weeks. So she said, here, this will help you. She said, the audit sheet that they give you was terrible. That woman turned out to be, she was an auditor for a hospital. She handed me an audit sheet. And can I tell you, to this day, I still use that audit sheet. It was amazing. And had I not had that contact, I would have never had access to it.
Yeah, that's the only thing that I think, and hopefully they've thought through that, and maybe they've made some sort of concessions. I don't know what that looks like, but hopefully it won't be to the detriment of the local chapters. Yeah. I just came over here in the Clubhouse. Tanika is a fool. She said, Jesse, the tea got you hot already. Oh my goodness. Oh, okay. Oh, KK says that she has a specialty exam today and she's getting my peppermint. Yes, girl, get that peppermint. The peppermint is good for you. Keep you alert and engaged and paying attention, and provides concentration and all the things. So we always have bags of peppermint for the examinees, even if, we would tell them, but even if they didn't, we would have some there. So cool. So yeah, that was the big AAPC thing. I saw it popping up everywhere, and I said, well, I'll just spill that little tea on Saturday. I won't go into all of that. Another thing I wanted to make mention of is there was an article by Carrie Greenwood, and she talks about the importance of credentials. And I think the name of her article is Surviving Uncertainty, Why a Coding Credential is Even More Important Now. And she has some interesting concepts and some interesting things. When I read one sentence, all I could think about was you, and I just chuckled and probably grasped my pearls at the same time, because I could hear you in my head, like, well, I'll say it. So it says, her article quotes, credentials have always mattered. They indicate mastery level skills and commitment to the profession. That's when I said, well, wait a minute. I know somebody, but let me read on. Employers use credentials as a shorthand method for indicating a coding professional has the level of knowledge and professionalism needed to handle the always changing landscape that comes with the business of healthcare. That right there just stopped me in my whole tracks. But I was like, you know what? That may have been her experience. And, nobody can take anybody's experience away from them. However, I know my friend, and I knew my friend would have something to say related to that. So let me grab my teacup as I let him chat on.
I think by now, everybody knows how I feel when it comes to this foolishness. Because, if you don't have a credential, and I think that's like my issue. I have such an issue with recruiters nowadays, because if you're going to have people recruiting for a certain industry, they should be well versed on the industry.
Yep.
And what it means and what these different credentials mean. I had an interview with a recruiter yesterday, and I'm having to explain to him the difference between coding and CDI.
Wow.
And then he's like, oh, well, that makes sense. That's interesting.
So how many people you done turned away, or how many people you done,
Exactly.
Wow.
And then he's like, well, then he's looking at my resume. Well, you should try to put this on it. You try to put that on there. I said, well, you do realize that everything cannot go on your resume. My resume will be 27 pages.
Exactly. And it is important to kind of craft your resume or craft the cover letter to the position that you're looking for or sending the information for. But you even that is work, and if they don't understand, the industry, and they don't understand what you're saying and what you're talking about, I mean, look at the time and energy that you've put into that to do that, and they're clueless. That, bless their hearts.
Because then he was like, well, because it's they're recruiting for a coding lead for some company, and you have to manage like 12 coders. So he's like, well, I don't see where you have any any supervisory experience on your resume. I said, the LPN after my name. I said, nurses run entire units and supervise the entire unit. And I've done that for like 20 plus years.
Wow. Wow. Yeah. I just, and I don't know. I don't know if the HR function or the HR recruiting function is niched. So do you have those who are specific to like health, a specific industry? So do you have somebody who is just with healthcare? Do you have someone who is just with, and not even healthcare? I mean, because healthcare can be broken down into all kinds of things as well. So do you have, I remember, so did you get in touch with the one dude who said he commented, I think, on the LinkedIn post, and he said that he was a healthcare recruiter?
Yes, I did.
Okay.
I haven't heard back from him, but I did.
Oh my God, here it comes. I told y'all this morning, boy. But he seemed to set himself apart and set himself out as specific to health information. What'd you say?
He seemed to.
Oh my God. Okay, let me grab a little more tea before we move on to the next. Okay, so maybe that could be something that they can think about. But this was the one thing that she did put in the article that I was like, oh, 100%, absolutely, kudos. And I 100% agree with that. So a coding credential or any credentials that you have belong to you. You can't, as long as you keep them current, and your dues don't have anything. She said pay your dues, but your dues don't have anything to do with it. Oftentimes there may be recertification fees. Now you have to pay the recertification fee, but not necessarily your dues. Those are separate. But if you pay your recertification fees and of course keep up with your continuing education, nobody can take that credential from you. That goes with you wherever. It's not a job. You don't lose it. It helps you. And it's not like a title, or it's not technology that can be replaced. It is you, and it marks you as proficient in, well, it marks you as proficient in those areas. So that's one of the things that I totally agree with. That's yours. It's up to you to make sure you maintain it and keep it up, but it's yours that you can take with you wherever you go. So yeah, that was a very interesting article. I thought you would enjoy that.
What I think AAPC and AHIMA both do lousy jobs on is they don't explain the differences in their credentials and what they need, because most people have no clue. Because I think most people who come into medical coding, they don't even know what it is they want to do.
Correct.
All they know is they want to, I heard about coding, I want to get a certification.
Correct.
And there's all kinds of ways that you can get into it. There's a path of entry along a whole lot of points. And you need to, a lot of them don't even know what you can do, let alone how to even get into it. Because like if you want to get into risk adjustment, like you don't have to learn CPT to do that. You can just learn ICD-10 CM.
Correct.
And if you want to work inpatient, now with the CIC, you don't even have to learn CPT.
Correct.
Because I just think that there needs to be some adjustments, because like there's not enough explanation, and people are just out here giving people advice willy-nilly, and it's like it might not work for them. That might not be what they need.
Right. And then understanding, what, to your point, understanding what your interests are, because what you need to know from an inpatient perspective is different than what you need to know on the professional side. What you need to know on the outpatient kind of have your foot in both. So, I guess that entry level coding information session, if you will, should happen, that kind of breaks those things down so people understand. If this is what your interests are, then this is what you need to focus on, and this is what you need to master, and then this may be the certification that you're looking for. Maybe something like that to break that down, because you're right, it's folks are all over the place, and it doesn't help that you have these organizations that have competing credentials too, for the same group of people. Like, you got the AAPC and AHIMA, both have their inpatient coding credential, both have a professional coding. I mean, it's all over the place. And so, yeah, that's you're absolutely right about that. There needs to be some further drilling down to people who are interested in health information, specifically coding, to understand what it is, and then understand, that can be just your starting block. You may want to parlay that into something else. You may want to get into auditing. You may want to get into, like you said, risk adjustment. You may want to get into the data analytic side of things. So just understanding what would best serve you, what's cost effective, and what would best serve you getting into this field. So yeah, you're right about that. Yeah.
Well, as we're talking about coding and credentials, what I think the industry, especially AHIMA, is kind of slipping on is, there is a huge push in the country for people to get into cybersecurity. All you see now is I've seen so many commercials about how many cybersecurity professionals the country needs. And we know they don't really like to talk about it a lot, but we've had major major institutions have been hacked, like healthcare organizations.
Yes.
And they had the ransomware scam.
Correct.
So, healthcare is huge. Cybersecurity is huge. And if you could marry the two, which AHIMA did with their CHPS credential, that could create a whole other pathway for employment, because truth be told, you really only need the CHPS, and you need the CHPS, and you need to either get a CompTIA, like networking type of credential, and you would be set.
Yeah.
And a lot of these people, like, I just think, I've said this before. Yeah, I think like the biggest joke is the masters in nursing informatics, because it's the jack of all trades and master of none. And you spend all this money, and then you have a hard time getting a job because you don't have any specialized skill in anything. And nowadays, technology is very highly specialized.
It is. You're right about that.
And that would, if you wanted to get into cyber, or to get into security, and you wanted to go that route, you could do that in 6 months. And be working. And because they had two cybersecurity credentials. They have one by this organization CompTIA, which is more entry level. And then they have another one that you have to have at least like 5 years experience. And the CompTIA cybersecurity is called Security Plus. That credential alone, you can start at $106,000.
All right. The options are out there.
Mhm.
Options are out there. Okay. So now I want to talk a little bit, and I talked to you all, and I mentioned this to you before about the ICD-10 Coordination and Maintenance Committee meeting. It was held just the other day, September 13th through 14th. And the information that they provide is basically giving you the behind the scenes of both the procedures. I think the procedure one is a little more, well, I won't say more interesting because I like the diagnosis one, but the procedure one is they, they really talk about the actual procedure and why they're doing it and blah 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 blah. And then they do the same thing for the diagnosis, but for some reason the procedure one is just it grabbed my attention more. Even though I like the diagnosis is mostly important to me. So this year, they sent out, like they do every year, they send out the packet. But I wanted to remind folks, and this is free. And years ago, you actually would have to make the trip to DC and go and get security clearance and all of the things to be a part of it. But it's virtual now. Some of the things that COVID brought us that were good would be one of these, would be this meeting. It's virtual. It's free. And you get CEUs. So I don't know if Brian puts this on his list, but this is one that comes, and I think it comes twice a year, and you get a CEU per hour, and it's an all day thing. So here is kind of like a conference, if you will, if you can spend the time. And I'm not 100% certain that you can use it for a replay. I'm not sure. I'll do some digging on that. But if you attend live, you definitely can use, because they do have recordings and you can go back and listen and hear. But you get CEUs from both the AAPC and AHIMA. So, and it's up to you to make sure that you keep the materials and all of those things related to that. So, the other thing I wanted to point out is that somebody is just very detail oriented in this space, because they got their calendar all the way out till almost 2024 included in their packet. And so the information that they gave at this meeting will reflect if everything is passed, because they're still in the process of taking comments. With the government, you have to have comments. So everything that happens here, so all of the proposed codes and procedures that were discussed, these are being considered for the April 1st, 2023 code changes. So remember, we talked about that they're doing it twice a year now. So not only is it you get brand new spanking books in October, but they also are providing new codes in April and new codes in October. So the September meeting is for the April codes. And then you have another meeting, I believe, in March. And the next meeting is March 7th through the 8th, 2023. And the March meeting is for any codes that will be considered for the October 2023 implementation of codes. So again, they list a whole program. So you can put all of this stuff on your calendar now to make sure that you have some time allotted to go back and double check and see if this is something you can plug into. Again, it's free. It's on, I think it's a Zoom. So they send you the Zoom link. You can get in there. There's something you need to do in order to be able to ask questions, but they give you all the details of that. Otherwise, you can listen, you get the packet, you get the information. As I said, my tea for the day, if you are an instructor, this is your bread and butter right here. This is where the information resides. Because here is where you can get the information about what's new, what's coming, and provide the why behind it, provide the information behind it. So some of the things that they are considering for April: codes, eating disorders. There's some additional codes on the social determinants of health that they're looking at, foreign bodies, migraines, obesity, and of course, because I am always plugged into my sickle cell community, sickle cell retinopathy. So it was way more than that, but those are just the ones I wanted to mention. And I'll probably do a more lengthy video talking about and post that in the upcoming weeks, and post that for some of the details. But yeah, just wanted to put that out there. If you missed it, you can still go back and, kind of plug into the replay and see what they're talking about related to where you make whole. I'm looking for the last day to respond to comment. I don't see that. Oh, November 14th. Yeah. So for any of the proposed codes, and they're not only they do the new codes, but they also do revisions as well. So for any comments that you may have on any of the things that they discuss, the last day that you can that they're receiving or taking public comments is November 14th. And the information on procedures you can find on the CMS website under their coordination and maintenance link. The information for diagnosis codes is on the cdc.gov website. So you go cdc.gov, and then you're looking for the NCHS tab, and that's where you'll get all the information related to there. Or you can always just do handy dandy Google search to get the information. Mr. Jesse, you have anything on that?
That document is really extensive, and they don't play when they give you the specificity and what they want. It's like, wow, like they're adding whole new code categories.
And this is how you are in front of that. Yes, this is where you can get the information to be in front of.
It's so interesting to really see the behind the scenes and how it makes it to the book and the entire process. This is very interesting.
Yeah. And so it gives you some context into, again, why you do what you do and how you do what you do, because they're kind of leading you based on, the changes in technology or changes in clinical practices or advancements in disease processes, et cetera. So all of that information, and they discuss all of that. So they have the experts behind, because somebody submitted the request or information for the addition of the codes or the revisions of the codes. And those somebodies show up and kind of state their case. And so it's a good time had by all for both the ICD-10 procedures and diagnosis world. So just thought I would revisit that. And again, I get September and March. Keep that on your radar. This is when you can get an opportunity to get a good hefty portion of CUs, because it's a 2-day conference and it's all day. So that's a good chunk for free versus like the one-off 1 hour here, 1 hour there. But if you have that time to spend. Okay. Let's see. And then the last thing that I want to bring up. So, evaluation and management is changing, and it's changing to not include the history and the exam portion for leveling your evaluation and management service. They are solely relying on either time or medical decision making. And I'm chuckling because I just saw an article the other day that was trying to push people into using time. And I was like, nobody is falling for the okie doke. But anyway, because that's low lying fruit. I mean, while time is a great indicator, my brain thinks from the compliance side, the auditor is going to say, wait a minute, your schedule said doom, 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 doom. You got somebody scheduled every 10 minutes here, but you're trying to tell me that you spent all of this time and you kept your schedule and you only here for 8 hours. That's low lying fruit and stuff don't add up. So, and a lot of folks understand that and like nobody is playing that game. However, the article I did read talked about which specialties it would benefit to use time. And so I do appreciate that. And so that may be something to consider. But yeah. But anyway, the problem, the thing that's happening now is when the office or other outpatient services section of the CPT evaluation and management codes changed a couple years ago, there was all kinds of information, all kinds of education. Folks were running and calling. Yeah, I even got in on some of the consultancies. You know, folks help us do this. How do we do this? What? That same energy is not here today as it relates to this inpatient stuff and the emergency department stuff. And so you have hospitalists, you have emergency department folks that are in the blind. They have no idea that this is coming and the impact that it has on them. I was reading the comment. Okay. And they have no idea. And the article I read said that they actually surveyed hospitalists and they were like, well, we're glad that this is changing, but we didn't know this was going to impact us. And so they don't even know what to do. The thing is, while it helps in reducing the documentation burden, quote, from CMS, folks didn't really document the medical decision making before. They were so focused on documenting all the history in the world because they figure, oh, if I capture all this history and I copy and paste and click all the stuff so the history populates, and then I do an exam, woohoo, I've met the bullet points for that level and I can move on, and not focused on, and that used to be my pet peeve because to me, medical necessity and medical decision making are married. And so I used to be like, well, why are you doing this? This medical decision making portion tells me the why are you doing this? And so when I would have my sessions with providers, that it would get intense. Write down, tell me on paper form, why are you doing this? Think in ink. So there's a whole level of training that needs to happen before all of this is going on. And nobody, it's like crickets out here in these streets. And I don't understand why. Why are they not putting that same energy toward these? Now, there are some who are dual. So if you have a private practice, then you already know the rules. You know what's happening. You got it. But if you are only in a hospital setting and you don't do that, oh my God, it's help them. Somebody help them. And I just don't. While the AMA wants to put all that energy in keeping nurse practitioners at bay, you need to use that same energy to make sure that your providers are educated in knowing what your changes are, because this CPT is AMA all day. What your changes are? Why are you? What? I don't understand. You want to? Kathy asks, but would the new E&M guidelines make HCC coding harder? Did you want to?
That E&M has
nothing to do with that. Yeah.
With the risk adjustment coding. That's based strictly off of the ICD-10 CM code.
However, In medical, there's kind of they're two different things because it's based on your ICD-10. But in your medical decision making is where your assessment and plan comes. So making sure that that documentation contains the assessment of whatever those diagnoses are. There, your link is there. So that's where your link. She said, well, I mean, there will be less information in the chart. Again, if they do a better job or a good job in documenting that assessment and then tying. So what we do as auditors, and I'll say this for a couple of my clients, and when we provide the education, you don't get credit if you, Lord, that's a whole other video that I'll be doing, like the problem with the problem list, because there is a problem there, especially if you have an automatic problem list that populates over into your assessment. That's where you HCC folks get into trouble, because all this stuff from the problem list are populated, but the provider has not even addressed none of this stuff. And then it's all showing up. And it's like, well, did they have it? Don't they have it? They didn't address it. What's going on? And it's listed and it's throwing y'all all out of whack. But that's another conversation for another day. But anyway, so we would tell them, if your system automatically turns on the function to populate these problem lists, ma'am and sir, somebody needs to document something in the plan related to that diagnosis. Because if there is no connection that you did anything related to that, it's not getting counted. Nobody is counting that. So you can have this 18 diagnosis list thinking that it's going to get you to the level 4 and level 5, but if you didn't there is nothing that you're planning related to that. And don't hit me with the return in 3 months or return. Don't do that. There's nothing else that's related to that. You don't get credit for that. And so again, part of those conversations for the inpatient, because they're going to be, oh God, they're going to be doing it even more. Because they document every single day while the person is in the hospital. And oh yeah, so it's even a whole different kind of level of information and education that needs to go out to them.
Well, I want to jump back to Kathy's point, because she had asked, will there be less information in the chart? It might be less information, but that still doesn't affect the information that we need as a risk adjustment coder, because you still will always have either a chief complaint or a history of present illness. Number one, you will always have some type of physical exam. And when you get to the assessment and plan, just like Clarice said, that's where you get into medical necessity, and that's also where you get into clinical validation. So those, as long as the plan can touch on what they diagnose and how they're going to plan to manage each of those conditions that they have identified in the assessment, then it's fine. It's going to be just like it was.
Yes. And then in the guidelines for evaluation and management, it tells you that you need to have a medically necessary history and exam documented. The thing is, and so that documentation, that stuff doesn't go away. It's still, the provider still needs to document that information. They don't have to go overboard like they have been doing because they're trying to get to a specific level. The thing is, that information in the history and that information in the exam will not be part of leveling the service. Only the medical decision making, or if you use time, will be the key factors in determining the evaluation and management code. So it's not like they're not going to have it. And you always got to have a chief complaint, because you got to know, why are you here in the first place? So all of those elements still need to be there. They may not be as, so it's going to be a flip. So where they used to didn't put a whole bunch of documentation in the medical decision making, that's where the documentation going to have to go now, versus all of the volumes that they would document in history and in exam. I hope that helped you.
It's so funny that you mentioned that, because I worked at a place about 3 years ago, and the senior auditor really had a problem with this provider. She thought that he was just being obstinate, and she wanted him to document a certain way, because he would put all of his information in the plan. Like, it just wasn't where she wanted. I didn't have a problem. He was one of my providers. I'm of the mindset, as long as it's there, as long as it's documented and I can code it, and because it's documented, I don't care. But looking back on it, he's really ahead of the game because his plan was extensive.
Mm-hmm.
I'm like, I've never seen anybody document like that before, but he was ahead of the curve because that's where it's all going to be now.
Yes, yes, that's where you have to support that. And I tell providers all the time, and it's not just for the money, which, in their mind, it's like for the money, but you got to think about the continuity of care for your patient. You got to think about, somebody else you may drop dead tomorrow. Somebody else gonna have to take care of this patient, and they need to know the information. What have you done? What was your thought process? What's going on? Now, of course, they're going to add their own spin to it, but it makes no sense to go back and make them have the same test or make them go through some of the same diagnostic stuff that you've already done if you documented and talked about, the reason why you thought this, that, and the other. Talk to your peer-to-peer in documentation about a patient and that patient's condition. So it's your medical record documentation, as we all know, serves multiple purposes. It's not just about reimbursement. So again, you hear, at least I hear from providers all the time who used to be like, I don't even read this stuff because it's fluff. It's a mess. Nobody can follow whatever. And hopefully, again, AMA, put your energy into making sure that your providers are well trained in documentation. Use that same energy that you're trying to. I'm sorry. Did I go there? Use that same energy. That's all I'm gonna say. Just use that same energy. It would be beneficial for everybody. I don't know. I feel like every time I think about it, I'm like, I don't hear the loud, hey, we got to get these physicians trained. And maybe they just rely on these systems, hospital systems and networks to do that. But I haven't heard it. I haven't heard it at all.
It's going to be a
mess. And then the other thing, because they're making some changes so the observation codes are merging into the inpatient codes. And so it's a whole bunch of stuff going on. And so yes, wait, let me see. She said, do you think providers should have training regarding? Yes, ma'am. Specifically, your inpatient, because again, if you're a provider that has your own practice and provide office visits, you already got this. You already know. You're already 2 years into this, so you're well aware. Somebody should have made you well aware of what these changes are and what you need to do, and so you just use those same concepts over when you see a person in the hospital. If you only provide services in the hospital, you could have been oblivious to what was going on in the office because it didn't pertain to you. But now it's coming for you. And so you need to know. And I don't hear where they're providing them with that information. And the other thing, like I said, the observation and the inpatient, also consider emergency. So you got somebody that's in an emergency. They normally put them in observation. What is all of that going to look like? How to tie in. And I was like, this is huge. This is huge. And then you have the 2 midnight rule. This is huge. And I can see the auditors sitting back like, yep. And then they're going to pounce. They are going to pounce.
Because what's going to end up happening is these people, these providers are thinking, because when it comes to streamlining codes, like for number one, I think the way that they currently have the observation codes are great. I think the way that they have if you're admitted and discharged on the same day separation is great.
No, that's not moving. That's going to be the same. But the observation itself, like you had the initial and the subsequent, that's moving into inpatient. They're merging them together.
But that's also hard because observation is an outpatient's designation. So then, if it's inpatient, then that becomes Medicare Part A versus Medicare Part B, and then
And so again, the education behind all of that is not happening. So
oh, you know what it is. I think it's a money grab.
Here we go.
Because seriously, because observation is a designation. You can be in ICU and be in observation status.
Correct. And years ago, and they've said forever, and I guess this is still going on because you don't have to have a designated observation space. You can have two people in a double room. One person could be in observation and one can be an inpatient. So you don't necessarily have that. But there was a line, my guidelines are over there. There's a line in what the CPT guidelines state about not having this designated space. And I'm like, y'all been saying that for years. Who is still doing that? I don't know.
Doing what?
I guess creating these designated observation units or spaces or whatever. Who does that?
I don't know anybody.
Well, somebody doing it because they made mention of it in the guidelines related to that.
I think that's the reason why I say it's a money grab is because they're trying to get more money for that bed. But the thing is, if that person is not inpatient, that's still not going to be the 2 midnight rules, and you still can't get paid for it.
That was the first thing I thought about, like, because I remember when that first came out and all of the foolishness related to that, and making sure that folks were educated and Milliman and oh God, the nightmare of that.
Because you mentioned Milliman, see now all of that has to be recalculated.
But again, to the point of what those were tools to get you to understand whether or not that wasn't the end result of determining whether or not it should be an inpatient. It was up to the provider to say, based on the condition of this patient, I think this patient will be here over 2 midnights. But anything could change. But from what I see right here in front of me today, I think this patient will be here over 2 midnights, and we will designate them as an inpatient or not. We will keep them in observation. So as soon as I read all of that, I said, oh my God, it's about to be a nightmare out here in these inpatient hospital observation designation streets. And nobody is educating the person who is the forefront of all of that, and that is the provider and their documentation. It's going to be a mess.
It is.
So I hope if you or somebody you know deals with hospitalists, ED physicians, anybody in the ER, please tap them on the shoulder and be like, do you know about this? And if you don't, let's have a conversation. Let's have tea.
So I have a question.
Yes.
So does that also mean that the guidelines are going to change for if somebody is, since they're merging the codes? Because there's a guideline designation that if somebody is admitted if they're admitted to observation from an outpatient surgery procedure, or if they're admitted to inpatient after being in observation, like there's certain codes that you have to use, like certain ones is the primary or principal diagnosis. Like if somebody had a procedure and they developed hypotension, then the procedure would be their observation diagnosis. That's what it currently says because of the guidelines. But if they merge those to inpatient codes, then does that change? Does that become, now you have to have a principal diagnosis versus this procedure as the primary diagnosis for the outpatient observation diagnosis?
Now, the merging of the codes doesn't change the observation status. So you can still have observation status and you will still have your inpatient status. They're just combining them in the same code set. So yeah. So it's not that observation in and of itself as a status is going away. It's just being merged into this particular code set. But you still have to know, your documentation has to support whichever way that you're going. Yeah. So
then that means now there won't be a separate discharge code from observation. You'll just use the regular inpatient discharge code based on time, or there still will.
They're keeping the observation discharge for whatever reason, but the initial and the subsequent are combined with hospital, with inpatient. Yep.
All right. I got
it. Yep. So, yeah, all of those things. I'm like, where is that energy? Rah, rah, rah.
Now, if we're here scratching our heads, imagine these poor.
It's like, oh my God. And I know, like I said, the first thing I thought about was the 2 midnight rule. I said, are you kidding me right now? But okay. Crickets silent. I said, okay. I don't know. I try in my whole life not to be a reactive individual. I like to be proactive. I like to kind of think through, okay, if I do this today, what is the downstream effect of this tomorrow? And, that's kind of how I move and shake in my whole little world, believe it or not. Because I believe for every action, there is some sort of reaction, either good or bad. And I just really try to be mindful of that. I don't know where that came, probably as a child, because, if you did something wrong, you got in trouble. I was probably trying to avoid the trouble. And see it, the compliance brain in me now is like, okay, how far up against that line can I go before I get in trouble? So I always try to, think through that. And I just feel like, did they think through this? Did they really think through this? And if they did, great. But are you telling people about it? Are you providing them the information and the tools they need to be successful in this? I'm not seeing that. I'm not seeing it. And that's scary because here we are damn near in October, because September is just about gone. It'll be here before you know it. And then you got to factor in, this is the time of the year, unfortunately, with a lot of systems because of their fiscal year. There's a lot of downsizing, a lot of rifts. There's a whole bunch of stuff going on in healthcare behind the scenes. And so it's about to be some shaking up and some turning over and some whatever. You got that. You got holidays. You got all of the stuff. And before you know it and blink, January 1 will be here. And then folks will be like, oh my God, I didn't have time. We didn't get to say. And then they'll be looking for grace. And then they'll be looking for this and they'll be looking for that. And, I'm just going to be sitting back like, yep. Give me a year or two. I'm coming for that. Coming for it.
While they're looking for grace, CMS will be looking for their refund.
I know. Exactly. So, yeah. Cool. All right. Well, those were all the things that I had for the day.
Don't you? I often, when we have these kind of conversations, I just think, I'm like, so many people who aren't in HIM, they're missing out on all this fun.
It is so much fun.
I mean, who knew? Like behind the scenes, it is a hot mess. But oftentimes we just go about our day and our stuff like oblivious to whatever. And it's like, no. That's why I said there's always some sort of opportunity. There's an opportunity. And we try to provide the information. Of course, we're only 2 individuals. I can't tap into everybody across the world. But if I tap into you and you can tap into somebody else, or you could send somebody else back to us to get some additional information. That's why we say share the information. Sharing is caring. And so, we can spread the news, that this stuff is coming. These are things that people need to have, and it even elevates you, put you
above someone that wouldn't know. And it's like, oh my God. And then, the thought leaders start thinking and start talking, and here we go. And then, hey, let's again have this conversation. Let's make sure we're preparing folks, because we're out here in these healthcare streets. Not only are we on the business of healthcare side, but we're also consumers of this healthcare stuff. And so, sir and ma'am, I want to make sure that you know what you're doing, and don't hit me with this crazy bill because you think this and my doctors be like, oh my God, because I'd be like, wait a minute, we were not here for 50. What you do, sir? Not on my dime. Sorry, nobody's doing that. They'd be like, oh my God. They'd be like, wait, you're the one that I am the one. Be like, do I need to talk to your coding and billing staff in the back? Do we need to have a conversation? Because sir and ma'am, no, we're not doing that. But yeah. So again, these are just some things that, as we're rolling into the new year and rolling into all of these changes with guidelines and the ICD-10 stuff right around the corner. So prayerfully, folks are taking the information and being proactive and understanding what's happening in that realm. Something I heard, I can't remember, something related to your HCCs and DRGs and that whole world. I saw something related to that. I don't remember what it is right now off the top of my head, but something related to that. So again, this is the time of the year. Well, really the summer, we tried to tell y'all, the summer is where you kind of get prepared for this, because it's here now. And so if you're trying to get it and you late. That's like, if you get somewhere at the time you're supposed to be there, you're already late. You need to be there early. And then if you come late, you real late. Don't be late. Be on time. Be early.
And if people think that these guideline changes are interesting and a potential hot mess, Clarice and Molly, and this credentialing is even worse. It's even more
I told you. Yes, it is. It's so fun though, isn't it?
I'm just saying, I'm glad I shaved my head already.
It is something else. And you'll be like, that did not say that. You did not, that is not.
And what gets me is like, I am just stunned at how oblivious practitioners are to the process by which they make their money.
Because they give it to somebody else. You handle that. What? You handle that.
Oh my God. I'm not that trusting. Not when it comes to my money. No.
They be like, you handle that. You take care of whatever. And yeah. It's interesting. It's a whole interesting. The revenue cycle is truly a cycle that is interesting. And each and every little spoke in that wheel comes with opportunities. Opportunities.
What I find fascinating, and I don't know where this came from, but there are some, I haven't heard a physician say it, but there are a lot of nurse practitioners who think, well, you don't have to be credentialed to bill an insurance company. You can just bill out of network. I'm like, that's not.
First of all, and you can bill out of network, but how advantageous is that to you? Nurse practitioner, being credentialed with a particular plan or payer is free marketing and advertisement. Every day, all day, because they're going to push your information. They're going to push you. They want to get people into your doors. It's to their benefit to get people into your doors for you to be seen. It's to their benefit and to yours. So connect with them. Now, again, it's the work of the credentialing process that maybe they don't want to deal with. So they feel like, well, they'll go out. But then you leaving money on the table too, because you membership has its privileges. I've always said that. Membership has its privileges, whatever they are. There are privileges to membership. Bless their hearts.
Yeah.
Or and then I mean you have these cash concierge type of practices too. And if you have that mindset, that's fine. But all those everybody can't do that. Yep. And to Tasha's point, the patient ends up paying when they bill out of network. You are absolutely right. And so think about your consumer, your customer, that patient. I know you trying to do your thing, but think beyond what you see right in front of you.
But they just think about the money, and then they don't even know what the reimbursement is. And it's like, that's just a cursory search. All this information is public.
Mm-hmm. Mm-hmm.
Like, because I have somebody who like they're billing Medicaid for a certain state. So I'm like, well, I said, well, yeah, okay, you want me to bill us, but you haven't told me how much you're charging for this service. Oh, well, maybe you can help me come up with a price. I'm like, well, first of all, do you know how much you're going to be reimbursed?
Exactly. And that's the thing that I sit there like, I've had conversations about some fee schedules. Like, are you kidding me right now? Like, first of all, you about to make somebody a whole bunch of more work because then they got to go back and adjust all of this foolishness when you only going to get $3, but you want to charge $200. Make it make sense. Make it make sense.
So then, they were like, well, I put down the CPT codes. I said, fine, for the E&M. I said, okay, fine. I said, but these are different levels. Are you going to charge the same price for each level, which you shouldn't, because each level pays differently? Oh, I didn't think about that.
And so don't forget, you got their contracts. So it's really based, especially on commercial side. On Medicaid side, it's cut and dry. It's easier. You can get that. But on the commercial side, everybody's contract don't look the same. It's different. So they may be paying your neighbor that's doing the exact same thing that you're doing something else than what they're paying you. So you got to make sure and don't have that conversation. Girl, so-and-so, yeah, they paying me so-and-so. Oh, well, they're going to pay. No, that's not what your contract says. No.
So I went to that particular state, Googled that state Medicaid fee schedule, downloaded it. It was a PDF. Downloaded it, copied the pages that they needed for their particular E&M services. I'm like, this is your fee schedule. Go to the non-facility road. That's what you get paid. Multiply that amount times 0.85, and that's what you will be paid. When I sent it to him, it doesn't make any sense. You'll have to explain it to me.
It's like, okay, as you start your time start.
Because that's another thing. Then I'm like, they're like, well, I have to send you their insurance card. For what? I just need their insurance number, their card number, which should already be in your system. All I did was scan them. I'm like, oh, okay. So if you need me to set up your clients in the system, I can bill you for that because they should already be in the system. But if you want me to do it, I gotta bill you for it.
I gotta drink the orange water now, Lord, and I kind of drink up all the tea. One of the things that I see, and I'm put somebody that's a new provider on game. If you all don't take the same amount of time, energy, and effort to make sure your front end processes are tight, oh my God. Oh, money is going all out of the door because your front end, these I bet you commercial folks are like, Come on in to these new folks. Yes, because y'all about to get free. It's about to be a bonanza. I should just go to visit all new providers so I can get all my services for free. Because folks are getting all kinds of free services because folks have no idea how to put together that front end process, and then wonder why all their stuff is being denied. Wonder why they're not getting paid. Because your front end process is garbage. Please put it together. If you don't know, ask somebody who does. Please.
How long does it take to verify eligibility?
Verify eligibility. Verify that the person has that insurance that they present with. You know there's a such thing as like insurance fraud, right? You know that there are folks identity they not just doing identity theft to steal somebody's credit card to go buy stuff. You know, it's a whole underground market where they're using identity theft to get healthcare services. Do you know how much money is in healthcare? Oh my God. That's a whole other conversation. And it starts with that front process. Getting that insurance information, verifying that insurance information. And I tell, especially my behavioral health clients who deal with Medicaid and managed Medicaid, because the managed Medicaid services, you know, they got a new gimmick every 30 days because they're trying to get you to come over here and be a part of this network or come over here and be a part of that network. So the gimmicks is out there. And if you the type of person who looking for the gimmick, what is it? I'm about to pull out a whole hood term, but it's not coming to me right now. The hookup. You looking for the hookup. You looking for what can I get out of this? So they dangling all these carrots, and you like, bet I'm moving over here to get that. Well, you are seeing this provider on a regular basis, and you haven't told them that, well, this new payer is giving me XYZ for 30 days, and I get free gym memberships, or I get this, that, and the third. And so I jumped over here, but you ain't told them, but nobody has asked them. But you still sitting there, and you're gonna get your regular treatment, your regular therapy, your regular whatever. And so when it comes time for you to bill it to the insurance that they had the month before, you wonder what happened? Well, you didn't even ask them. Is this your current insurance? Can I see the current insurance card? That's front end process. That's front end 101. Maybe we should have a front end 101 revenue cycle process course. See, I be talking myself into courses. Look, I'm helping somebody out there. I'm helping somebody. I don't have that many hours in a day, but I'm helping somebody. Oh, yes.
People jump into it, and they don't really. Then once they realize they have jumped clear into the deep end.
The deep end with no life, no safety jacket, no life jacket, no nothing. You just flailing out there.
Because there is a whole misconception just across the country that billing and coding are so easy. Just because it's advertised on
the midnight infomercials, or daytime during the court shows or whatever.
Yes.
Like
they think it's easy. Oh, well, that can't be hard. It's just it's simple. Okay, all right.
Mm-hmm.
Wait till you get it.
Lifelong learners are what we are.
You better be.
Yeah.
What applies today might not apply tomorrow.
Hey, and as we've said, today's price was not yesterday's price.
That's right.
Where the money reside. And she says, and that's why some providers don't like Medicaid HMOs. Too much work involved for them. That's right. Especially on that front end. If you don't have that process put together. Well, this was good.
Yeah.
This was good. You have any closing thoughts, sir?
No, just once again, I'm just glad you created the space. We try to bring as much information and provide value because we talk about things that I don't hear anybody else really talking about. who are in medical coding, and they have these, they have these programs that it's all fluff and whatever. This is some meat and potatoes. This will
Even for the vegetarians, because I'm a vegetarian, so.
Well, this is impossible meat and potatoes.
Beyond, I like Beyond Meat.
Okay,
Not
Beyond Meat. So I know, Diana, I'm very excited, and I hope that people really get, what we're trying to do here.
Yes, and we're trying to put everybody up on game, from the provider community to the actual coder, or the health information professional, be it coder, biller, wherever you fit in compliance, wherever you fit in that cycle. And then also for the education community, we spilled some tea over here for that. And then the entrepreneurial, because if you see the gaps, you know where you need to start creating. So we try to help everybody in an hour or so's time. So yeah, so thank you all for joining the Saturday morning tea with us today. Was the tea spilled? Was it spilled?
Yes,
if this information was valuable for you, help us share this message with others by liking the video, sharing the video. And I guess I probably should say, when you come in the room, bring a friend, share it, tell somebody, hey, they on and they talking. And they might be talking about something that you need to know about. But then we also have the replay, so you can go back and check out the replay as well. And also subscribe to the channel. I'm reading comments. I'm sorry. Subscribe to the channel, the Professional Reimbursement Network. You can also check out the Coding Nurse YouTube channel. He has some gems over there as well. Last but certainly not least, to my Clubhouse folks, make sure you click on the greenhouse. I heard in somebody's Clubhouse room, was it today? They said it's the Green Mansion. I said, well, all right, click that Green Mansion. Forget the house. We want the mansion. Click that Green Mansion to join in the fun in our club. And you'll get notified of our live broadcast, which happens on every Saturday morning at 9 a.m. Eastern Standard Time.
One last thing.
Yes, sir.
When you were talking about my channel, I want to say this to everybody who has a business. Make sure you trademark your name. Just like we talked about earlier with Darrell.
Mm-hmm.
There was a young lady who created an LLC. For 2 years, she had a very successful business. Somebody went and trademarked her name. So she's on here. She was on this video in tears because now she can't even use the name that she created.
Oh, wow.
And that is the power of ownership.
Ownership. Woo! We can go in on that one just all day.
Because I will tell anybody, like I'll just give you real quick. How it works. When you put in your application, you're guaranteed a spot until your application is either approved or denied. Nobody else can, they can come, but they have to wait until your case is decided on before their application can even start the process. So that's the power of ownership. And the day you file your application, you can use TN. Once your application is approved, then that's when you get the R for registered.
Oh, okay. I didn't know that. And
so
then
if
register.
you have an idea and you have it could be something like silly putty billing and coding. You better trademark it.
Where the money reside, where the money reside.
Somebody else in California might have the same idea. You just spent money on a website, a domain, and Instagram, and then somebody can come, because truth be told, somebody on because my Twitter is the Coding Nurse _. Somebody on Twitter has the actual The Coding Nurse. And I could legally go ahead and say you can't use that. But I'll let it rock, because I mean they don't really use it, and it's not like it's doing anything anyway, and I'm not really on Twitter like that, but I'm not going to. But I have the legal authority to do it.
That's right.
Because
Ownership.
I own
That's
that.
right. That's right. But look at the last minute tea being spilled. I appreciate that. I appreciate that. Yeah. I've had people come to me and ask me questions. Well, you know, how can we get started doing X? I was like, that's a whole other, that's a whole other thought process. The why and the how behind all of this. But yeah, therein lies another opportunity. So I don't know. Maybe we can put together something related to it. You hear our look, see, let me move on. So if you are if you subscribe to the channel, you will also get notifications of our weekly our videos. And then if you missed something, or if there was something that was just juicy, then, you know, again, we make the audio available in Clubhouse, as well as the videos available on YouTube. And then I don't never pull the stuff down from Facebook or whatever. So I think that stuff is out there too, because I don't pull it down. It just be out there circulating. So wherever you join us from, you can always go back and check out. And, you know, again, share the information with others. The more people we know, the better the reach. And hopefully we can make some of those impacts on all of these groups that we have been talking about today to help ultimately each other. You know, I always pride myself, and I believe that's why Mr. Jesse is my kindred spirit, because we both believe in being resources for people. Yeah, you know, sometimes there's maybe a fee associated with, because we got to eat too, but oftentimes we're putting you up on game for free. Look at all the stuff that you got today for free 99, game for free. So that is our service. We give up an hour. Actually, we give up more. We give up an hour or so on Saturday morning, but trust and believe there's some behind the scenes work that happen throughout the week to prepare for this. And again, we do it because we are trying to help you. So help us, help you, and help others. All right. I hope that was good for you today. This has been a great, great session. I've enjoyed myself, even though, you know, I was nervous. I thought something was going to jump off, but it turned out. It turned out. So again, thank you for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care. Have a great weekend. Talk to you soon.
Bye-bye.
Bye.